Quality of life has been maybe the least recognized element of what would be called the triad of decision making, where the triad of decision making for most cancer treatment has been efficacy, how effective are the treatments, toxicity, what's the cost of that effectiveness in terms of adverse events and side effects, and then lastly cost. And I think that we've been translating the toxicity as the equivalent of quality of life. So it's interesting that in my work, I've gotten to work not just with oncologists, but other specialists. And in rheumatology, there haven't been, like there have been in cancer, these bidimensional measurements of progression. So a patient gets worse because of symptoms. And it's been a problem in the field. They want objective measures. So there was an objective measure developed called a CDAI score, Clinical Disease Activity Index. And it's very simple and straightforward. How many joints are swollen? How many joints hurt? On a scale of 1 to 10, what does the patient feel is their burden of disease and treatment? And on a scale of 1 to 10, what does the physician think is the patient's burden of disease and treatment? It's such a simple question. It's almost like, how are you feeling on a scale of 1 to 10? We've studied that, and when you look at the physician's assessment, it generally underestimates the patient's perception of their burden by about 30% on that scale of 1 to 10. So the patients are always averaging 4s, and the physicians are saying, no, it's a 3 on terms of the burden. So it's a really interesting concept. I worry that we get so caught up in the complexity of these complex quality of life measurement scores that we miss sometimes the simplest things you can do, just asking simple questions, but also logging them into the record on a continuous basis to see the impact.
Yeah. I mean, it's true. Some of the measurement scales are really complex as we're looking at QoL, and they're really not. Some of them are not that well validated. But I think again, from looking at a payer perspective and looking as we have to make policy for them, we do have to try to measure it somehow. I think we just have to get better at it. To some extent, to have some of these instruments a little better validated, still simple, straightforward, and patient-friendly. But I think to have something that's some good validation, especially from, again, the payer standpoint, creating payment around those things, is going to be very important. And from a clinical aspect, knowing what treatments actually work. So quality of life is important, but measurement's a problem. Like many things in medicine, it's a domain of quality of care. But to manage is how does it affect your patient's quality of life, and that's too is something that the measurements are not as clear as we'd like them to be. There are some metrics, as you well know, about looking at quality of life and some of the patient-reported outcomes. There's the MD ASI, MD Anderson tool, and there's the European Trialist tool, which are pretty good and have been pretty well validated. So I think there are some things that go out for some of those patient-reported outcomes that will affect quality of life. There are also some of the other reasonably validated things, the SF tools, the Optum from the Optum, the FS. I think they go from 16 to 36, or they're variety of tools with more complexity as they go up with somewhat more increased validity, and there are some pain indices. So I think there are some validated tools that we can begin to use and to look at it. And I think the real question is, are those things for policy? We're going to look at those in terms of policy making, or how would those affect individual patient decision making, and how could an oncologist use that for a particular patient, or is that something we need to do more on a systems level?
Yeah, I'm concerned again. One of my biggest concerns with looking at any of the tools is their complexity. So how sophisticated does the audience have to be to use that tool effectively? What's their literacy level? Health literacy, numeracy, problem solving, so they can really address the questions in a meaningful way.
And what's the cultural relevance from one culture to another, and some things that are relatively subjective? Right. Yeah, exactly.
And what are the resources it will take to get those things done, and done repeatedly in an office environment, whether it's office in a private practice or in a hospital setting? What is the staff that's going to be needed to capture it, then document it, report it, monitor it? I often feel, it's so often in our field, in the field of oncology and in medicine in general, and especially now that we're in healthcare reform, that the perfect becomes the enemy of the good. Instead of having a good idea, a pilot that was done, it's a simple thing, do that one thing, take one step forward. No, it's got all these flaws, and we can't do that. And then we go back and we spend 10 years, kind of going through this process of cerebrating over what could really be perfect. And I wish if we could only keep taking these one steps in the right direction because it's good, I think we'd make a lot of progress.